your view about similarities and differences between pediatric severe asthma, and I mean school-age severe asthma, and severe asthma in adulthood, and what can we learn from each other?
Are you asking me?
Yeah, you and Andy and Robin.
You talking to me?
I'm talking to you, yeah.
I'm going to speculate. I think much of it is hormonal. And what we didn't do in UBioPred was to balance the groups, girls, boys, age-wise, in a way that would permit us to, because that wasn't the study wasn't big enough. I think you'd have to do a match, almost comparison between, because as you know, you pediatricians know that better than we do, that there's that transition from girls, from girls to boys. Or rather the other way around, sorry. The girls start to catch up. And so I think one would have to redo an analysis to try to control for gender rather than simply look at age. But I believe ultimately it will be the role of the hormones, which will link the pediatric asthma to adult asthma.
Also in terms of Robin, I mean, we as Robin just mentioned, we've been working in the same department on my 40th and my 50th birthday, and that was a long time ago. So thanks for reminding me that. But interesting thing is the pattern of disease is changing, and what you get in your adult severe asthma clinic, you inherit the patients that we see. Do you perceive that there's going to be further change in the pattern of severe asthma going forward?
So I was going to reflect on our transitional experience and looking after young people with severe asthma. And we run a joint clinic with our paediatricians whereby we meet the young people from the age of 14 onwards. And what's very apparent is, in addition to the specific, non-asthma related transitional factors that Claudia's alluded to today, just how many of the issues are so similar to the ones we have in the older adults, but are actually more magnified. And so we get an overrepresentation of young people with severe smoking habits. We see, in the worst cases, young people who are losing lung function through the early teens, through smoking all sorts of substances, and poor adherence to basic asthma care. We see a very high level of mental health disorders. These are the patients that actually, I think, worry me and our team the most. They need a lot of input from CAMS, our child and young person's mental health care. I think that these patients, that we only have maybe 10 or 20 young patients in our service with this degree of severe asthma, but I think that they are disproportionately sick, certainly in terms of their asthma, but in particular in terms of their adherence to therapies. And we spend a lot of time trying to get on top of not just the asthma, but their adherence to biologics, their attendance and so forth. Interestingly, I think many of the patients that we see are not particularly allergy-driven, which is really interesting, and I think that was a surprise to me 10 years ago, but it's been validated by research in the London group, hasn't it? I think that a substantial proportion of late teenagers with severe asthma are T2 high, but not necessarily allergy-driven. So much more in common with the later onset adult asthmas that we're more familiar with.
Any questions at this point from the audience? Please just raise a hand. Microphone is going to come. If not, I'm perfectly happy to continue. Yeah? There's a question here.
Hello. On behalf of the fifth-year medical students of University of Sarajevo Faculty of Medicine, we have formed a question regarding severe asthma. So some argue that sharp style phenotyping delays treatment in severe asthma, and we should instead treat first and then refine later with biologics. So we students would love to hear your take. Is over-reliance on biomarkers slowing down the treatment in severe asthma?
I didn't catch that. Okay, did you catch that? Did you hear that? Didn't catch that? No.
Can you just repeat the question? Just the last bit.
So is phenotyping delaying the treatment of severe asthma? Should we treat it first and then define it later with, sorry, I have it written down. So is over-reliance on biomarkers slowing down treatment of severe asthma?
Over-reliance.
Yes.
I don't think one can ever over-rely on understanding, on knowledge. It's what you do that matters. And you only do based on the evidence. So, you know, the evidence is very clear that if you measure pheno, or if you do blood eosinophils, it helps you. It helps you understand what is going on. So, in principle, I would like every patient, when they get their diagnosis of asthma, is to be analyzed as deeply as possible. Now, of course, there are limitations. There's money, yeah? Then there's availability of the lab tests and so on, which are, you know, which are reality, you know, you have to live within that. But the more you understand, the better the doctor you will be.
But are we losing time in all those diagnostics when we could be treating patients instead?
There's a terrible echo.
Yeah, there's terrible echo, yeah.
Okay. No, that's a sensible question, but I think, you know, as long as you're not wasting a lot of time, but, you know, how much time does it take to take a blood test? And I think, you know, if the patient, of course, if the patient is severely unwell, you know, if their first presentation to you is in a severe state, then yes, you have to treat, of course. But I think most people present in a condition where there is some flexibility, so you can, you know, you don't have to rush, so you can take simple. It's not difficult. Blood tests and do spirometry and reversibility, and there you go. So you start with an understanding of the naive patient. Everything else has been masked by the intervention, and the intervention may be correct or may be completely incorrect. So, that makes sense?
Yes, thank you.
Other questions? Very quick questions for Andy. And, you know, this is something that we've been discussing a lot, the extrapolation of data in adults to pediatric context. So when you look at biologics, overwhelming evidence is in adults, and then it's extrapolated in pediatrics. And I think the beautiful example of that is relatively, or well, considerably lower benefits of mepolizumab in children than in adults that were only ascertained when studies in appropriate age group were done. So does this difference in response to biologics, or apparent difference in response to biologics between adults and children, tell us something about the disease and causality and presentation?
So I think there are two aspects. The first, obviously, is that children and adults differ in the normal ranges of various biomarkers. For example, the blood eosinophil count, which you guys have as 300, rightly, you've got evidence that 300 is the upper limit of normal. In young children, that's actually below the average. So that's irrespective of disease. So we need to think about biomarkers. Muppets 2, which was the mepolizumab study, you can argue you compare that with the DREAM study, and the results are incredibly disappointing. If you torture the data hard enough, you can get a p-value out of it, but it really is not very exciting. And again, there was a study from North America showing that BAL-IL-5 increased with age. So maybe that is the explanation why it does so much better in adults than it does in younger children. But the moral of the story is we need the studies in children. You know, how many parents here would be happy to take their 6-year-old to a doctor and say, well, this works fine for a 27-year-old man, so it'll be fine for your 6-year-old child. I don't think many parents would be terribly impressed with that as an argument.
Claudia has a question, but before she asks a question, I'm going to ask her a question. Because we're talking about this continuum from childhood to adulthood and the transition. And you spoke so beautifully and eloquently about transition. So the question is, how much of transition is generic and how much of it is disease specific?
Thanks for that question, Adnan. So I would say most of the skills in delivering a good transition process are generic. It's learning how to speak to young people and not be shy about addressing difficult topics, sort of setting the scene for the young person but also for the parents so that you get both of them on side. And then there are quite a lot of other skills, like people need to learn how to get their own prescriptions, how to access medication, how to access healthcare, regardless of where you are, whether you're in the UK, whether you're in Bosnia, or whether you're in New York. You need to work out how do you actually get hold of what you need to treat your condition. And we need to help young people to really get on board with learning the strategies to do these things, to fit it into their lives and help them work out why that might be a good thing, that should matter to them, because if they don't work out that it's helpful to have controlled disease, they're not going to work towards it. And then once you know the generic transition skills and you can, deliver developmentally appropriate healthcare, the allergy and asthma and eczema specific bits, they follow, they slot in quite easily.
Mirela.
Okay, just a short question. Could you please comment, is it possible to obtain long-term remission in a patient by biologics? Long-term, especially in the kids, in the children.
In children or in adults? In children or in adults?
Please, you can comment also for adults, and also maybe someone can comment, is it possible to expect in the children as well?
Was the question about long-term remission in asthma on biologics?
What do you think?
Yeah, so
in years?
So if we take a single outcome for patients, adult patients with severe asthma on a biologic, as we saw this morning, they are very effective. They reduce their annualized exacerbation rate by up to 80%. And similarly, for patients on maintenance oral corticosteroids, the majority of patients will come off. As you say, though, looking at the definition of remission, it depends on your definition.
Okay.
What we really want to achieve is good asthma control. So in the UK or internationally, we measure that by the ACQ test. So you're getting your ACQ down to less than 1.5. Abolishing acute attacks, getting them down to 0, and taking people off maintenance steroids. And if you look at that composite endpoint for remission, all the biologics perform roughly equivalently, and it's around about a third to maybe 40% at the most will achieve those 3 components.
Okay.
If you put in the fourth criterion of improving lung function, then obviously you're making it more stringent and the figures fall a little bit.
Yeah, but I would like to discuss with you, but that is not a complete remission. For instance, we know that's the clinical improvement. I think the remission, if the patient stop with the therapy, they will be completely without the symptoms, with normal pulmonary function, without hyperresponsiveness. Is it possible to reach with biologics?
Isn't it? Such an interesting question, which is definition of the term remission, which fundamentally differs between pediatric and adult care. Andy was...
That's right.
I think what is important, Mirjana, is, as you know, there's now initiative by pediatric PEARL, pediatric asthma in early life, to go on and try to define remission in pediatric terms. Andy?
Yes, so a couple of comments. I think the concept of active versus burnt-out disease, which we heard about in rheumatology, is something that is really important. And I suspect there's the relative proportions of active disease to burnt out, much more active disease in children, and the much more burnt out with remodeled, obstructed airways in adults. And therefore, I suspect you will get more benefit with biologics if you start them early in the active disease. And there was that big Blue Journal paper, I've forgotten the first author, it's probably you, but there was where they looked at the factors predictive of remission by various diagnoses, and one of the things, the earlier they started and the fewer courses of steroids they had, the better they did. Yeah. So that, I think, is an important concept. I think one of the things that troubles me is a paper written in the Blue Journal again, 20-odd years ago, by Johan de Jongster. And he took teenage and adult patients who, to all intents and purposes, were in remission, off treatment, no exacerbations, no steroid bursts, no nothing. He bronchoscoped them and biopsied them, and there was no difference in the airway histology between those with active asthma and those who were remitted asthma. And I don't understand that paper. I know you're completely straight.
We probably need to get back to these. Yeah?
You remember that paper, Adnan?
What happens to them 20 years later is what we need to know.
What happens? Are they in the mean? And again, there are data, aren't there, that raised blood eosinophil count in the population predict a more rapid decline of lung function, but actually trying to persuade these people who are completely well to take treatment is next to impossible.
Claudia has a question.
Yeah, thanks. I mean, people always get very hung up about the excitement of biologics. And in my experience, certainly with eczema, I don't do that much severe asthma, it's actually a tiny proportion that requires biologics at the end of the day, and it's really hard to get them on it. So I have two questions. One, what is actually the number of people in the total population of asthmatics that you think will need biologics in kids and in adults? And my second question, being ever the pragmatist, is if you didn't have the biologics, what's your number one thing for each of you that you would change that your patients could do? And thirdly, how can you harness community resources like pharmacists and others to identify those who need the biologics?
Well, I can't answer your first question except indirectly. Of those who are referred to our tertiary centre for consideration of biologics, less than 10% actually need them. The rest need to get the basics right. And I don't know what that proportion coming to the Brompton of the general population, but I'm anticipating my second talk, but getting the basics right is just so fundamentally important. And we don't do that, at least in pediatrics. Robin, you were saying you have a very different system within adult care, and it works much better, but certainly it doesn't work in peds. Getting the basics right is so important.
Audience, any further questions?
Can I just add to what hasn't been said? Past exacerbation predicts exacerbation. So once you've had an exacerbation, your risk of having an exacerbation is higher than somebody who hasn't had an exacerbation. And what does exacerbation mean? Exacerbation is just an extreme form of asthma attack, yeah? Which does not resolve with usual treatment, which is bronchodilators and inhaled steroids. So it's an extreme form. And something happens in the lungs. And I suspect something happens in the perception, the neural networks inside the body, inside the CNS, the vagus nerve and sympathetic, parasympathetic nervous system. Something happens that conditions the subsequent response. And then, you know, I think both of you were talking about anxiety and the perception, which is terribly important. So my preferred option would be, and I'd love to do a study of that kind. I don't know whether this would be totally suitable for children, but certainly for adults. The first time that a patient has a severe attack that takes the patient into hospital, I would start them on a biologic and see what happens. Because that's when you get them. You get them when they are in that, at the cusp, you know, when they can still tilt back. Once they've had one attack, another attack, after another attack, then the pattern ceases, they grabs them. And the immune system works in a rigid way, but also the mind, the central nervous system, works in a rigid way. So early intervention is, I think, what we need if we want to change. I don't know whether we will ever cure asthma, but at least if we want to markedly change the outcome, the long-term outcomes of people, so that we can have some kind of parallel that we have now, thanks to your team at Imperial, that we have with food intolerance, that you have a long-term situation where you don't have anaphylaxis. You have something that looks unpleasant and so on, but you don't completely seize up. You don't. So I think there are really nice parallels between the treatment of food allergy, you know, that results in anaphylaxis and severe asthma.
Yeah, but in food allergy, we actively sort of cause their symptoms. Andy?
So I'm just going to slightly disagree with you, Ratko. I would say if somebody
in English, this means he disagrees a lot.
Yes.
But that's what's called diplomacy.
Yeah. So if the first attack is because the child hasn't been taking their treatment and has been smoking cigarettes,
I was talking about
and
adults.
has 5 pet cats and they're cat sensitized, I think I'd tackle that first. And you said this, I think, for the biologics. For me, if you have an asthma attack, the first thing you do is complete reappraisal. What went wrong? Can you stop a further attack? If the answer to that is no, then you go for biologics. You don't wait for a third or a fourth or a fifth attack or whatever NICE wants us to do. But I think you need that. The cardiologists teach us that. Myocardial infarction, there's a focused response. What went wrong? What can we do to stop it happening again? And that is pivotal for asthma attacks.
Yes,
I think what we're going to have next year, guys, is a session which will be disagreement between the speakers. That's the most interesting one for the audience. Did you have a question over there? I think you did, yeah. Middle and Vildan.
Yeah. Okay, hello. I hope you can hear me. Okay. So I just like to point some excellent lecture about Professor Bush, about the vaping. So the situation is very dangerous. So what do you suggest? What will be the urgent measure? What we should to do immediately, tomorrow, to improve that approach regarding the vaping in adolescents, for instance?
So you need politicians who are less stupid than ours.
Okay, so how?
You want they should be treated just like tobacco. No advertising, no displays, no smoking in public places. If the adult doctors need to use them for smoking cessation in a controlled manner, so be it, I defer to them. But there needs to be, if you sell vapes to a child underage, you lose your business. So there's some really effective penalties. And how you control access on the internet, I don't know, because all you have to do, say, I'm 18, tick, yes or no. Well, a 17-year, but political action is essential, and to break through this sort of miasma of saying, oh, they're so safe, they're fine, they're wonderful. No, what they are trying to do is to create a generation of nicotine addicts. You know, and that's why they're targeting children. If I get addicted, I'm an old man, I'll be dead soon, they won't make much money from me. If they target a child and a child gets addicted, that's an income for life. So get on, bend the ears of your politicians.
Robin.
So Sonia is not with us right now, but wanted to raise a question about the role of the pharmacist in improving access to good asthma care. And I think there are one or two pharmacists in the audience who maybe wanted to explore this, so I said I'd bring this up. I mean, we've talked a lot about biologics today, but clearly it's going to be the minority of patients that need a biologic, but there's still a lot of patients out there who need better asthma care but don't need an asthma biologic. And we see this in the United Kingdom, we see it everywhere. Just to really say that in the United Kingdom, we are developing the role of the pharmacist and have something called the New Medicines Contract, whereby pharmacists now can counsel patients on how to use their inhaler, they can suggest some treatment switches, they can intervene and make urgent referrals to the local doctor. I think the summary point is that different healthcare locations will require different innovative solutions, but we are looking at the role of beyond the general practitioner, beyond the general practice, into healthcare professionals in the community to try and improve asthma care. And these may be solutions that you're looking at as well here.
Vildana.
Just to thank you for this point, because we always try to find solutions for our specific region. We are lacking of specialists, we are lacking of nurses. We know that our health professionals witness a lot of problems as well. But this is the way how pharmacists can be mediators, or they can help in improve asthma care by exact education of the patients. Yeah, so exactly. I just wanted to
and I mean, you're doing a fantastic job with your asthma schools, and for those of you who were here 2 years ago, Andy gave absolutely fantastic talk of getting the basics right and getting those basics right. We've reviewed few patients here yesterday, and the problem was not getting the basics right. So how do we roll it out in a healthcare system like this? That's a real problem, but that's a problem for you rather than solutions that we can give you.
If I may say, the Minister of Health of Canton Sarajevo will be here at 4 o'clock. So that's a great point. We do that as a patient organization, and I see some of the doctors from different clinics that we do together, these kind of school of atopies and asthma school, but this should be systemic solution, something that goes with, which is in the system. So I just wanted to stress that, and thank you very much. And there's another question from Victor. Yeah.
Sorry, patients taking over the question. So I discussed this with Dr. Gore yesterday. So in GAP, we work globally, and the same problem that you have in this region, the lack of specialists, not only in allergology, immunology, but also mental health, because they go to study to another country and they never come back. It's mirrored in many regions on the world. We have this discussion in Costa Rica, in India, and many places that they go to the US, to the UK, never come back. So that exacerbates the problem regarding mental health, right? So we saw in our survey 17% of patients with comorbidities, they think about suicide. So mental health is a real problem, but when you only have primary care, in many countries they only have access to primary care, right? Those 10 minutes, obviously your primary care doctor is going to focus on the clinical intervention, on the treatment, the test, and then your time is over. Mental health will not be touched because there is no time. So I know we cannot solve this problem easily, but I don't know if we have any ideas on how can we change that paradigm? Sorry.
Yeah, so that's a really tough ask, and I think we all struggle with that. Really interesting data that Claudia showed this morning on the regularity, or rather lack of, or the confidence with which healthcare professionals, I think that was a global study, ask specifically about self-harm. in our clinic, we actually ask regularly, and the part of the examination of any patient, but particularly the young person, is rolling up the arms to find the self-harm scars. And once you've done that once and seen it as a doctor, you never forget it, and then you begin to pick it up and you gain confidence in asking the question. But I think, we find access to mental health care extremely difficult, and that's even in a better resourced healthcare setting. We have our nurses and all our team are trained to access the crisis team. That's for the patients who are at acute danger of serious self-harm, but dealing with the great weight of psychological ill health in the community at primary care level, I think is even less well provided for. I don't have a solution, but it's,
Claudia.
Yeah, if I can add to that, in my clinics, a lot of the young people struggle with their mental health, and anxiety is a particular issue. It's not always health-related anxiety. It's often around exams and school and pressure and social media. But there is a substantial component that's added by poor disease control. And certainly we can help with that as a team. And I mean, I have to say, in my clinic, I hold quite a lot of the mental health issues and we talk about it. And I think acknowledging that they have anxiety or other mental health pressures is step number one, because if you don't talk about it, it's a hidden thing. It's a source of shame and stigma that people are afraid of. So having the courage to acknowledge it helps them to feel a little bit more okay about it. And then we can help certainly the element of disease control. And that's a gift that we all have, is that for the majority of patients, with what we have, we can make an enormous difference. Most of the patients who come to me with extremely severe eczema have never been shown how to correctly apply their treatment. They've never had a written treatment plan for which cream needs to go where at what times. They've never had a regime that works, that isn't 5 times a day, but maybe once a day, that's realistic for them. And those are so basic. Every single person in this room who delivers healthcare can do exactly those things and ask the question. And it does not cost extra money. It costs maybe a little bit of extra time. It does cost courage to do it. The first time I asked the question, do you self-harm? And I got a yes back. I was like, oh my God, what am I going to do now? But you learn what to do with that and how to have those conversations. So I think we can do an awful lot with even very little before we get into having a psychologist and having I think we all are much more able than we give ourselves credit for, and we can learn more on top of that.
Just to say, we've trained all our nurses. We had our psychologist train all our nurses in the basic elements of psychological assessment. So it's to roll out some degree of psychological medicine competency within our team. And often it's made the difference between allowing them to ask the right question, and so the young person maybe will call us for help when they otherwise wouldn't have done. So they're then in the system. So that's relatively cost effective, I think, even if we don't have armies of psychologists on tap.
And if I can add one more thing, I mean, I'm a pediatrician. I look after children and young people. It's parental mental health that's incredibly important as well, because if you don't help the parent and acknowledge their anxieties and whatever else might be going on, and sort of help them, maybe give themselves permission to seek help as well, then there is another obstacle in the room. And parental poor mental health is such an enormous factor for poor childhood outcomes. So I think that's another aspect to consider, is in certainly in pediatric care, and that obviously extends adult patients, extends to them.
Just to emphasize, as one of the speakers said, it's not the lungs. I think it was Radko. It's not the lungs that enters your clinic, it is the whole patient. And this impact across all of the different domains of health is quite substantial. In eczema, it's catastrophic, and both Claudia and Neves know very well about it, and we'll hear about it later. So, yeah, it's very, very, very easy to be organ-based specialist and forget about everything else, and it is also fundamentally flawed. Please, guys, make every opportunity to talk to speakers. It's a unique opportunity. At this point, I'm going to cut this conversation and discussion, which was absolutely great. I enjoyed it, in order for us to try to get into some sort of timing so that people can make it earlier rather than later at the end of the day. Thanks very much, everybody. Thanks for your contribution. Thanks for the conversation.